Would our speakers from this session please join us on the stage? We have a few minutes for questions.
I just have two questions in regards to the aspirin. Aspirin resistance, is it checked for in your patients? And then a well-controlled atrial arrhythmia. Do you guys still put these patients on anticoagulant plus aspirin or antiplatelet therapy?
Thanks for the question. So I don't know if mine's on either, but for the aspirin resistance, we do not routinely check for aspirin resistance. We just prescribe it in patients who don't have a clear indication for full anticoagulation. The other question was about well-controlled atrial tachyarrhythmias. Our concern is that the incidence of clots is very high, and so if somebody has a well-controlled atrial tachyarrhythmia, we will typically be aggressive about putting them on anticoagulation for that.
And just to mention one other aspect here, it's the potential utility for the newer anticoagulants, NOACs, non-vitamin K dependent anticoagulants. There isn't much data out there, but Dr. Lurie showed a recent publication from the NOAC registry looking at 74 patients, Fontan patients, who were placed on NOACs. And I believe there was only 3 major bleeding episodes in that group and no thromboembolic events. So we're looking at potentially using NOACs in some of these lower risk patients. A little bit hesitant to go to NOACs with some of the higher risk Fontan patients with active arrhythmias and older RA to PA Fontans where we would still favor warfarin therapy. But certainly we have a growing number of patients that are now on some of these alternative anticoagulants.
Dr. Franklin.
Hi, great. Thanks for a great session this morning so far. 2 questions, one for you, Jamil, and one for Dr. Prosper. First, liver biopsy, you mentioned you do it every time they do you do a cath on those patients. Is there a certain frequency, every 5 years, every 10 years?
Wayne, that's like...
Because that could be a lot of liver biopsies.
Yeah, way to ask the really tough question. There's, honestly, I don't know how often is the right answer. We have essentially said we will go in every decade for unstable patients, but in reality, many of our patients have needed catheterization sooner than that, and we have a handful now that have had multiple biopsies over the years, and we have seen actually progression of degree of fibrosis even over a 3 or 4 year period. So I'm not sure how frequently to biopsy, but I think if I'm in there, I'm getting useful information if I do.
And then for Dr. Prosper, stress MRI, do you guys use it? Is it ready for prime time? Is it helpful?
Thanks for the question. So we do offer stress MRI. I think it's great for the right patient. So if the patient, can tolerate regulus and stress, we can, determine if some of the areas of coronary stenosis are functionally significant. In terms of ready for prime time, I think it depends on the location. So we perform all of these on the UCLA campus, where we have a radiologist present as well as a nurse practitioner. We have all of the pertinent drugs and resuscitation cart and all of that available. In terms of mobilizing it out into some of our community practices, that's where it's a little bit tricky because you need a lot of manpower. It's very resource intensive.
Thanks so much for the talks. Really just a very basic question. I see a number of single ventricle patients, some that came through our own center, others that have come from other communities. And you guys talked about a little bit of the medications, the kind of stable Fontan that you can say, okay, they're doing well. And I realize I definitely have some variability on what medications they're on. Sometimes they're on an afterload reducer, sometimes they're on digoxin. Sometimes I actually had a kid that came from Houston, came back on a calcium channel blocker, which I hadn't been using. I mean, I'm wondering if there's sort of a consensus, okay, every 10-year-old Fontan kid that's doing well, what should they be on? And it's sort of a naive question in a way, but again, I see this variability in my population, and I kind of smile to myself. So
that's a great question.
No, that is a great question. I can't speak about the 10-year-old, unfortunately, because we see the once they are adult at 18. But we pretty much have everybody on aspirin, or if they need to be on full anticoagulation. The choice of ACE inhibitor or ARB, it depends. It's very individualized to the patient. And one thing actually I didn't mention, but that I should add, is we also favor using spironolactone a lot because it has been shown in limited studies, but it has been shown to improve endothelial function, which is, I think, critically important in Fontan patients. So I don't think there is like one answer fits all. It's very patient-specific. Same with beta blockers.
But one other point there that I would like to add regarding consideration of pulmonary vasodilator therapies in older Fontan. So if you saw the protocol that Adam was going through, there was in there this kind of strange thing. PDE5 inhibitor, is the patient a candidate for a PDE5 inhibitor, which I think most programs go, well, why is that even in there? We do feel that there's enough data now on the positive effects of PDE5 inhibitors in improving pulmonary blood flow and reducing pulmonary vascular resistance in Fontan patients to have it be another agent that's considered in the adult Fontan patient.
Dr. Roth.
Okay. Thanks for putting this together, and great talks. Everybody looks good up there. So I kind of had two questions, or to ask the group their comments. So you talk about the PDE5 inhibitors for the Fontans. Does anybody or anyone have a feeling or an opinion to use an ERA like Opsumit in place of the PDE5 inhibitor or in addition to, in referencing the Tempo trial that used bosentan, et cetera? It's a more expensive drug, but it's once a day and has less liver impact than bosentan, for example. So that's one question. The second one is, just anecdotally, I see you're doing some, for some of these caths, you're doing exercise testing in the cath and getting these numbers and looking at EDPs, which is great. You know, for the more sick patients, it would seem logical that the EDPs are going to go up. They don't feel well, they have diastolic dysfunction, et cetera. Have you just noticed, have you done this for a more healthy Fontan that you've cathed? And what are you seeing less increase in the EDP? Because I don't really know what a normal EDP is when you're exercising. Perhaps they all go up to 25, or are you seeing the less sick patients not going up as much?
So why don't I answer the last question first regarding the EDPs and regarding selecting patients for exercise testing. It's frankly quite challenging to convince a healthy, well-functioning Fontan patient to agree to go in and get an awake exercise cath. So that tends to be one of our limitations, is just the in selecting who goes and gets them. You know, Dr. Lax, for example, has argued for many years that it would be very useful for us to do this in all Fontan patients who we get exercise data. And I think there's, you know, a lot of weight to that particular argument. But our choices end up being in many ways driven by which patients are willing to accept what. And so therefore, our sicker patients in whom decisions need to be made regarding Fontan conversion, AV valve repair, for example, fenestration closure, introduction of further medical therapy, transplant selection, etc. That's where, and in the presentation that I showed you two different patients that had stress testing. One patient, the stress testing told us that the patient would be acceptable for Fontan conversion. Why? Because the EDP didn't go through the roof and the PA pressure did not go up. Your EDP should not rise to 25 when you exercise in a normal human being or in a well-functioning Fontan. Whereas in the other one, they had very decremental hemodynamics, and so that patient was sent for transplant. So we're using it really as a means of making a decision or helping us make a decision. But I do think we're underusing it, frankly, and if we could find a way to more efficiently do it in pretty much everybody that came to the cath lab, I think that would be great. But I do think that's challenging. Regarding pulmonary vasodilators, ERAs versus PDE5 inhibitors, Dr. Clift is going to speak to us in the second session about his experience in England, but we are involved in a multinational trial now looking at the use of macitentan, the Rubato trial in single ventricle patients. So those that are willing to be part of that trial, we're enrolling in that trial. Why do we use PDE5 inhibitors in preference at this point? Because frankly, the data is more convincing at this point with PDE5 inhibitors than it is with ERAs. At least our interpretation of the data is that. We may find that in the long run, ERAs will be standard therapy as well. But for now, we don't think that we have enough convincing data that everybody goes on an ERA.
Great. Hi, Jill Steiner, University of Washington. Thank you all for your wonderful insights. My question is for Dr. Small. Can you recommend, or do you have recommendations for a specific tool for advanced care planning or materials that you point your patients toward? And then what is the best way that you found to make that result of that, conversation, their needs, wishes, whatever, available to others who may be caring for the patient if you're not around?
That's a great question. So I guess the first one was about the structure and the output of the conversation with advanced care planning. So I think that the way that I frame this is the biggest sin that we commit as a medical community is not communicating people's disease and prognosis with them. And so that is always my starting point, is what is your understanding, what's your kind of big picture? And we had lengthy conversations about this in the past. I tend not to discuss numbers with people, the median survival of a Fontan. But I say, I worry that through the next 10 years, you're going to start having arrhythmias and things like that. So that's like major sin committed by the medical community that I always try to address right off the bat. And then after that, we sort of start to get into surrogate decision maker and things. In terms of papers and resources for our colleagues, we have an advanced directive that we use. The advanced directive is used on everybody who's undergoing a transplant workup, and we're trying to increase its use in the clinic. And I think it's hard to decide exactly when. There are patients who come in who are doing pretty well. They haven't really thought about this at all. They're like 20 years old, and it's a lot to just sort of go into the advanced directive with them. But conversely, you don't want to do it too late when someone's already really getting sick, and so that's a very tough one. When I'm not there, I think there is a sort of advanced care planning part of our notes for the stable Fontan, and then there is that advanced directive document, which we kind of encourage ourselves to use, but haven't decided exactly when to kind of pull the trigger on that.
Great.
So,
Thank you.
Thanks. A lot of really great questions, but we do want to give you guys a coffee. We do want to give you guys a coffee break, bathroom break. We will be up here. If you could bring your questions to us, please. While everybody's taking a break, that would be great. Please reconvene back here in 15 minutes.